Good evening and welcome to our webinar today on empowering recovery with medication-assisted therapy, that is MAT. Please give me a thumbs up if you're able to hear me. Thank you very much for that, and thank you again for joining us for this webinar. I'd like to introduce our panelist today, the person who will be taking us through the presentation, Dr. Jacqueline Ochieng. She's a consultant, a specialist psychiatrist at the Mathare National Teaching and Referral Hospital, and she's based at the Methadone Clinic. She's also the chairperson of the Employee Wellness Committee at Mathare National Teaching and Referral Hospital, and she has interests in management of addiction, and she's well placed to take us through this topic of today. And also her interests are also in youth mental health. She's also a former secretary of the Kenya Psychiatric Association, and she loves traveling to new places and values time with her family. And my name is Diana. I'm a psychologist at Mathare. I'll be moderating the session for today. Welcome, Dr.
Thank you very much, Diana. Let me just share my screen. Diana, do you have the presentation? Perhaps you could share it for me. Sorry.
Yes, sure.
Full screen. Okay, so thank you very much once again for giving me this opportunity to present on medically assisted therapy. And this is in management of opioid use disorders. The outline of my presentation, I'll just share with us, the next slide, I'll share with us what the WHO harm reduction package is about. And then an overview of the MAT services that we have in the country. Then just give a brief of the MAT services at Mathare Hospital. I'll take us just roughly through the opioids, and then how methadone and buprenorphine also come in handy to manage these opioid use disorders. So according to the WHO UNODC comprehensive package for HIV prevention amongst people who inject drugs, we have about 9 aspects. The first one being the needle and syringe exchange program, which has been going on in the country. And it's done in some of the CSOs that we partner with. We have one called NOSET and another one called SAPTA. Then the second one is opioid substitution therapy, but we refer to it as medically assisted therapy, and I'll explain to us what that means. There is HIV testing and counseling. Then there's offering of antiretroviral therapy, prevention and treatment of sexually transmitted infection, condom programs for injecting drug users and their sexual partners, targeted information, education, and communication for injecting drug users and their sexual partners, vaccination, diagnosis and treatment of viral hepatitis, prevention, diagnosis and treatment of TB. So this slide is really to explain to us how the program came about for the first time in the country. It was really to help reduce the prevalence of HIV amongst the what we call the special populations, and in this case we have the people who inject drugs. And it was found that the HIV prevalence in that group was about 3 times more than the national prevalence. Hence there was need to actually have targeted management for this group of people. So the next slide just shows us the estimates of the people who inject or use drugs, and in this case we are referring to heroin. which is the opioid of concern. So in the national estimates, we have roughly about 35,784. And the number of counties that have people who inject drugs are actually all the counties, but about 14 of them that are offering services that are targeted towards harm reduction. The counties that have MAT clinics are 7, and they're targeting a population of about 16,007. So the clinics in Nairobi County are 2 of them that are managing just about 5,024. So we have one in Ngara, and the main one at Nairobi, at Mathare National Teaching and Referral Hospital. The next slide shows us some of the sites that we have. Nairobi having most of the clinics, and you can also see that we have mobile van services that are bringing the services closer to the people. And then we also have a prison dispensing sites. Then we also have a decentralized fixed dispensing site in Kiambu. So when the program started in Nairobi, it was rolled out in Mombasa and Kilifi, and it has grown throughout that coastal region, as well as Kisumu and Kiambu and Thika. So the first clinic, as I mentioned, began in Mathare, and this opened on the 8th of December, 2014. As at the end of May, we had 1,757 clients enrolled. Majority of them are males, and we get referrals from the CSOs that I mentioned. We have NOSET and SAPTA that have been in existence even before the clinic started, managing some of these services in the harm reduction package. And so at Mathare Hospital, we operate as a multidisciplinary team. And as I mentioned, our clients are a referral from the CSOs. The next slide, please. And so once these clients are picked out as eligible for the program, they are referred to the hospital, escorted by the peer educators from these CSOs, and we register them at the reception. They'll be taken through triage, and then they'll be assessed by the psychosocial department, where we have counselors. Then they're sent to the laboratory for a urine drug screen, toxicology, to just make sure that we are dealing with opioids before we can manage the clients. Then they'll be seen by the clinician, who will take them through a thorough assessment, and now dose them for the methadone. From there, they will take the methadone from the pharmacy as a directly observed therapy. And in case there's any need for a review, then they can be reviewed by the clinician. I'm just giving an overview of what happens because there's really so much, but we may not have much time to delve into the details. So I'll just begin with this slide that classifies psychoactive drugs. I know we had a presentation some time back by Dr. Siengo, just talking about some substance use disorders and how to manage some of them under the topic of addiction. And so I'll just give general classes. I'll not go into the details, but of interest to us are opioids, which are in the class of depressants. Alcohol stands first in that list. And then we have benzodiazepines, the likes of diazepam, clonazepam, amongst others. We have opioids, and I'll go into details about the classification of the opioids. There are solvents and barbiturates, and then cannabis in low doses will act as a depressant. Amongst the stimulants, the most common ones, we have khat, which a lot of arguments have been going around regarding whether it's a drug or not, but it's classified as a stimulant. There's caffeine, nicotine. Cocaine is also available in the markets, and amphetamines and methamphetamine and MDMA. We also have hallucinogens. Of most common interest is cannabis in high doses, and there's ketamine. Some of these are available, but not necessarily in the country. So I will just discuss the common things that we deal with. So in the classification of opioids, we have the pure opioid agonists, and then we have the semi-synthetic, the synthetic ones, and then the partial agonists and antagonists. So the pure opioid itself, we have morphine, we have codeine, we have opium, which is from the opium poppy plant, and we also have papaverine. With the semi-synthetic ones, heroin is one of those. We have hydromorphone and oxycodone. So of interest again is heroin, which we have been trying to manage as a problematic substance for addiction. Then in the synthetic ones, which fall under the prescription medication, methadone is one of those as a synthetic opioid, which is very useful in this management of opioid use disorders. We also have pethidine, which has been problematic. It is a prescription drug, what we refer to as DDA, but unfortunately, especially in the healthcare profession, we find that it's abused, or also some patients who may have undergone some surgery or going through chronic pain are prescribed pethidine, and unfortunately, it ends up being a substance of abuse. Fentanyl is also of concern. It may not be an issue right now in Kenya, but in the Western world, it's a big deal, and it's really giving people a headache in terms of managing its addiction. Then partial agonists and antagonists, we have buprenorphine, naloxone, and naltrexone. It's important to take note of this. I'll be discussing roughly, briefly, where their importance comes in. And so, as I mentioned, the main setup for the MAT, or medically assisted treatment program, was really to manage people who inject drugs, heroin being the drug of concern. And so the reasoning behind it was that with heroin, which is a short-acting opioid, it has an onset of action within 6 to 24 hours. And the kind of effect that it would have is such that withdrawal symptoms would come up very fast. And so the clients are always spending their time trying to look for the next fix of heroin so they can be comfortable. I will mention this withdrawal symptoms so that you can understand why it's been a challenge trying to manage, and for them to keep having use this heroin. And so to be able to take care of these withdrawal symptoms and help them comfortably navigate the withdrawal symptoms so they can have a meaningful life, we introduce methadone, which is of the same class, but it's a synthetic opioid, and has an onset of onset of action 24 to 48 hours, and the duration can last 10 to 20 days or even more. I'll explain that in the slides that follow. So I'll just give us a brief introduction about heroin so that you can understand why it's a problem. So heroin, and it's taken in through different routes. They could be the smoking or injecting, but injecting is a problem because the population that we're dealing with, due to the nature or the urgency of trying to fix a withdrawal symptom, they would find themselves sharing needles and increasing the chances of spreading the HIV. So heroin in itself is broken down to morphine. And this morphine is what we pick up when we have a urine drug test, is what we pick up as the substance amongst the panel of drugs that we look out for. And the fact that it is lipophilic, in fact, it's attached to the fatty cells, it has a more rapid action. It's excreted in urine, and that's how we are able to detect it from the urine drug screens. The metabolites are present in urine for about 48 hours following use. And this is important because then if somebody used heroin, probably like 2 days ago, you may not be able to detect that in the urine. So some of this information is important when you're getting history and also trying to find out whether you can make a diagnosis of opioid use disorder. So the immediate effects of opioids, you'll find that someone will present with altered perception, where they're euphoric, a sense of feeling high. For those who are light-skinned, the flashing, the face or the skin will look a bit brighter. They'll have a sense of tranquility, peace, or contentment. To some extent, there could be also delirium. The opioids have an effect of relieving pain. So to some degree, they would experience that. Impaired cognition, here we're talking about attention, concentration, maybe some memory may be affected, as although consciousness may be preserved. The autonomic nervous system is affected, and you'll be able to see how that works. Suppression of the cough reflex, and I think this brings to attention codeine, which is usually used in cough syrups, might actually be a substance of abuse if not taken, if you don't take care about that. Someone will present with constricted pupils. There's urinary retention, reduced gastrointestinal motility, which would present as constipation. And if one was to take this in high doses, then would result in respiratory depression and coma or death. And so that's why we are really, really concerned about issues of overdose. And that has also been a problem in this population that use opioids. And the long-term effects of this opioid use, which is as a result of dependence or poor general self-care, criminal behavior, or drug impurities in some of these drugs, we might have constipation, which might result in a narcotic bowel syndrome, and it's actually now a problem that would have to be dealt with. There could be cognitive impairment from hypoxia as a result of repeated non-fatal overdoses. There might be reproduction and endocrine irregularities. I think this is also something that we saw among some of our female clients who have not seen their menses in quite some time. There could be medication-induced headaches and intense sadness, which would tend towards depression or dysthymia. Some of these photos that are presented, you'll notice that the skin is not the Kenyan or African skin, but this helps us to be able to see some of the things that we would look out for as track marks for those who have been consistently injecting the opioids, especially heroin. And unfortunately, some of this might complicate, and one would result in venous abscesses, and which is shown in the next slide. So those are some of the things that we look out for when you're managing our clients. So withdrawal symptoms, signs and symptoms, what we look out for, and these are also well documented in what we refer to as the COWS scale, Clinical Opioid Withdrawal Scale. So the signs, or what you would see someone present with, are yawning. They'd be yawning quite frequently. Tearing of the eyes, the pupils would be dilated, sweating profusely. Many times they'll present with a runny nose as if someone has a flu. They would have tremors, and then some goose pimples, and diarrhea and vomiting are some of the signs that would pick out. They might not all present, but you look out for those. Then the symptoms that someone would present with, anorexia, which is lack of appetite or nausea, abdominal pains or cramps, hot and cold flashes. There'd be a lot of pains in the muscles and the joints. Present with lack of sleep, craving for the drug, and a sense of restlessness or anxiety. And so if someone experiences this every 6 hours or so, of the withdrawal from the opioids, you'll find that it's such an uncomfortable space to be in. And that's where we come in to assist in terms of managing some of this. So management of the withdrawal, as I mentioned, we have the scales that we use to guide treatment. And if you have access to it, you can check out it's called COWS, COWS, to just see the scales that are there. But we'll be talking about mild, moderate, or severe withdrawal, which also guides us in terms of what dose to give of methadone when a patient or a client is beginning treatment. And sometimes if we notice a withdrawal pattern that is not following the usual signs and symptoms that we are aware of, we might want to suspect other conditions so that we can manage accordingly. And so the management really is a sense of reassurance and supportive care. In the next slide, it's important to give the patient or the client information regarding what could be happening to them and how we'll be able to manage and assist them in terms of to navigate through this withdrawal. Hydration and nutrition is very important. And sometimes we might have to do symptomatic management of these withdrawal symptoms, targeting every aspect that somebody might present with. So if it's the pain, abdominal pain, we give painkillers, antiemetics in case there's an element of vomiting a lot. We have clonidine, we have benzodiazepines or antispasmodics. But now you can imagine somebody with a prescription that has all this medication. That's where opioid pharmacotherapy is coming, methadone or buprenorphine. And that has actually proved to be such a big help in terms of managing clients who present with this. It's also important to note that we on the opposite of withdrawal, you have intoxication or overdose. And what would happen is that someone might present as unconscious. And that means that if you were to call them or to try and get them to open their eyes, or when you speak to them or shake them gently, they will not respond. So as I mentioned, the withdrawal symptoms, they have dilated pupils. So in this case, would have constricted pupils, perhaps even pinpoint. The person would be breathing the respiration rate would be too slow. And then instead of having the sweatiness, in this case, would be finding somebody with a cool or moist skin. So these are signs and symptoms of an overdose, which would require an urgent response. So thankfully, I hope you remember the slide I shared about the antagonists. We had naltrexone, we had naloxone there. So naloxone is actually an antagonist, which helps reverse the overdose effect of the opioids. And it has actually helped a lot in terms of trying to take care of some of our clients who most of the times would be overdosing in the drug dens. And the fact that it works very fast helps us to reverse this effect. So really, for us to know that it's been a successful reversal, then what you'll be eliciting are withdrawal symptoms, which I shared earlier. So in a nutshell, management of the intoxication or overdose, it would be more of like a resuscitatory kind of aspect, making sure that the airway is open, the person is breathing well, and the circulation is working well. Naloxone is injected and initially intravenously for fastest action, and it will act in about 2 minutes or so. Effects may last about 45 minutes. The dosage is there, and a lot of the times, the people who are working in the dens or in the CSOs are advised on how to administer the naloxone. The maximum dose really would be 10 milligrams. Beyond that, then would require management in a hospital setting for close monitoring. So the next slide will show us the treatment pathways that we have for a client who is using heroin. And most of the times, by the time they're coming for management, we are talking about dependence, whereby they actually cannot stay without the drug itself. And so when they get into the program, then we will be talking about withdrawal management. And the main aim would be really to promote abstinence. The other aspect would be maintenance treatment, and that's where we have the methadone and the buprenorphine. Then even as we're taking care of these clients, we're talking about relapse prevention. We know addiction is a relapsing disease. And so the support that comes in would be really, if it is in a rehabilitation setting, either residential or outpatient, psychological counseling is really the mainstay of management, being part of support groups, and also giving naltrexone as a relapse prevention medication. And then, as I talked about in the beginning, harm reduction, we really need to talk about overdose and also reducing the risk of HIV or hepatitis C, amongst all the other infections that are spread by sharing of needles. So I'll talk about methadone now. I'd already mentioned it as one of those synthetic opioids. It was first approved by FDA in 1947 as an analgesic, but it had a very relatively short duration of effect. And since 1964, it has been used for maintenance treatment of opioid dependence. And it's available in oral formulation as a solid tablet, rapidly soluble wafer or liquid solution. The picture that you see on the right is one of the dispensing, our dispensing machine for methadone in the clinic. And so that goes to say that we use the liquid solution. So when you're talking about methadone maintenance therapy, we refer to use of an opioid agonist, in this case, which is methadone, prescribed medication for management of patients who are dependent on opioids. And methadone is really considered as the gold standard for treatment by virtue of the long half-life that it has. I think you saw the graph that I shared earlier. And it also has, it's a mu agonist with morphine-like properties and actions. It is a CNS depressant, and effects usually last about 24 hours. It has good oral bioavailability, and that's why you take it orally. In the next slide, the peak plasma concentration is after 2 to 4 hours, and 96% plasma protein bound. It's stored extensively in the liver, and its elimination half-life is 24 to 36 hours, and a steady state achieved within 4 to 5 days. So the reason this information is important, because that explains why when we give methadone given orally, that's a plus, because then we don't have the option of injecting. So it reduces the risk of spreading HIV or the other bloodborne infections. It achieves the peak plasma concentration after 2 to 4 hours, and so you're able to notice the effects, to be able to manage the withdrawal symptoms. It's stored in the liver, and this has an implication in the sense that if the liver has any issues or any problems, then we might want to watch out in terms of the dosage that we are giving. But also the liver usually metabolizes a lot of many other drugs, including in our case HIV, ARVs, and anti-TBs. So it guides us in terms of managing the dosages of methadone versus the prescribed treatments for HIV, TB, amongst others. The elimination half-life of 24 to 36 hours is important, because then compared to heroin, which is about 6 hours or so, somebody is able to be stable enough without being disturbed by withdrawal symptoms to actually achieve a meaningful day, so that they're not spending all their time looking for the next fix of heroin or maybe any other opioid that they may be using. And so this helps us navigate, some of the activities of daily living and even a meaningful or gainful employment for the clients that we are taking care of. And a steady state that is achieved within 4 to 5 days. It helps us to be able to know what maintenance dose we can, stabilization and maintenance dose that we can put our clients on. I'll be sharing that in the subsequent slides. So methadone is given daily, preferably at the same time. So we have clients, if somebody would come in the morning, then they'd rather come every day in the morning, so that then we can be able to maintain a constant blood level of this of the drug in the body. And once somebody has achieved the adequate dose, it actually prevents withdrawal symptoms. And those are some of the things that we look out to be able to increase the dose to a point where it is the client is comfortable and without intoxication. So the advantages of methadone is that it will suppress opioid withdrawal, because I think as you saw the signs and symptoms I shared, you find that the client will be very, very uncomfortable. And so to suppress the withdrawal, it allows them to be comfortable enough to do meaningful work or have a meaningful day. The fact that methadone, as compared to the injectable drugs, or especially heroin, methadone does not have any impurities, and some of these impurities are the ones that would also cause more complications to the clients when they're injecting. The fact that it's given orally also helps us in terms of reducing the risk for infection. And then once daily dose, as I'd already mentioned, enables us to have lifestyle changes. And the slow reduction and withdrawal can be negotiated with minimum discomfort. And the fact that it doesn't create this high feeling compared to heroin, then it allows us to be able to give it comfortably without feeling like you're introducing another drug that will create a high, because that is really what addiction rides on. We also offer counseling and support to just assist these clients to have a long-term lifestyle changes, and that will be shared by some of our the colleagues in the psychosocial department. It's legal and affordable, therefore there's reduced participation in crime, and then it has few long-term side effects. Now, the disadvantages that we've cited are that it might be a bit uncomfortable initially, because when we're initiating somebody on methadone, we'll be telling them, please don't go and mix, don't go mix with other substances, don't mix with heroin or any of those other CNS depressants, a term that we refer to as kuchakachua. So those who are in the methadone clinic will be able, you have to learn to use this language that they also understand. So opioid dependence is maintained. Now, this is the fact that they would actually have to be using an opioid to take care of an opioid addiction. But the good thing is that this is something that we can be able to wean someone off comfortably. There is slow withdrawal. This can take, it can actually take long. It can actually take long over time to be able to maneuver that. Overdose is a possibility, especially in the polydrug use. And the element that someone would have to come in daily and to take methadone, someone would feel it's a bit of a challenge in that sense. It has a variable duration of action, and the other problem would be the issue of diversion. So we also try as much as possible to be careful regarding that. The next slide, please. So the safety overview of methadone, as we mentioned, it is a safe medication, and the fact that we increase the dose gradually The primary side effects, just like any other of those mu agonists, are nausea and constipation, but it may be less severe. And there is really no evidence of significant disruption in cognitive or psychomotor performance with methadone. So what I had shared earlier, maybe just having this attention, concentration, and memory being affected, it actually improves performance in the clients. And then there is also no evidence of organ damage with chronic dosing. So just this is for information because I believe I'm talking to people in the health sector. The safe induction dose, we start with 15 to 30 milligrams. And I said this is dependent on a number of things. From the COWS scale, whether we have mild, moderate, or severe withdrawal, it will determine that. Also matters of maybe age, and if somebody was maybe expectant, amongst other things, we also need to consider that. Deaths have occurred with higher starting doses or polydrug use. And when I say polydrug use, this is where now somebody would still go use alcohol or use a benzodiazepine on top of maybe the methadone. So we have to give this information every single day for them to be careful. And sometimes it's safer to start them on methadone as inpatients, although, as you said, it has some financial implications. But we've had experiences where we've had to admit somebody in the ward to be able to navigate the first week or so of them taking methadone, so that then we are reducing the risk of overdose. So some of the situations where we've used 10 to 20 milligrams, for those who are older than 60 years, those who have used benzodiazepines or sedatives or antipsychotics recently, those who are using alcohol. And as I put in brackets, it's important to just, sometimes it's even important to manage the alcohol use first before we can initiate methadone treatment. Normally we say starting someone on methadone is not an emergency. We'd rather deal with the alcohol use first and see once a person stabilizes, then we can put them on methadone treatment. Any issues with respiration or CNS depression, we would not want to start on high doses. Cardiac arrhythmias, or somebody who is on medication that may cause liver or enzyme inhibition. So we have three phases of management, usually stabilization, the induction, stabilization, and then the maintenance. So the stabilization usually is where now we try to get a dose that is comfortable for the client. And we manage it. The first week really is very important. And so we'll navigate. Maybe if someone started on 30 milligrams, we might go all the way up to 40 milligrams. But by the end of the first week, we do not want to go beyond 25 milligram increase. And the subsequent dose increases usually are between 5 to 10 milligrams, gradually based on how the client is responding. And the best outcomes for maintenance doses are doses above 60 milligrams. But we also need to take note that for children, even 20 milligrams can be lethal. So we need to be very careful. Even, of course, in our case, we do not give methadone to children, but sometimes in case of accidental use, which I know hasn't happened, we need to be careful about that. And for an adult who has never quite used an opioid, anything as low as 50 milligrams can be fatal. So sometimes you might be tempted to find out how this methadone tastes. It would be good to just keep off completely. Otherwise, the result would be very devastating. So we review our clients regularly. Usually within the first week, we want to see how comfortable they are. We write prescriptions until the next appointment. And we always have to see the patient before increasing the doses. And this assessment continues as we build into the therapeutic relationship. What I need to mention is that this program, the minimum recommended stay would be 1 year, but we have clients who have been on the program for as long as it has been, which is probably about 8 years. So we need to be able to manage them accordingly and as the needs arise. We also screen and manage for comorbidities, both psychiatric and physical. And we also offer an additional screening for CA cervix for the ladies. Psychosocial support is offered at every stage, and the details of this will be shared by one of the panelists who is a specialist in the psychosocial department. So in terms of adherence, as we are stabilizing the dosage, it's important to also just address some of those psychosocial issues. And one thing that we've noticed that once somebody has stabilized on methadone, some of these issues, not having a place to stay, not having a job or an income, some of these things are easily addressed once the client is stable on methadone. And this also increases opportunities because we also want to reduce the spread of HIV, either by regular testing every 3 months, and for those who are found to be positive are put on HEART, it allows us to be able to follow them up and manage them effectively. So in the clinic, each client is assigned a counselor, and we usually have treatment plans. In the next slide, we have treatment plans written at induction, and all this is dependent on the needs assessment for the client. So it's not a one size fits all. And within the first week, the client will be reviewed, and subsequently as need arises. But we have scheduled appointments on day 30, 60, and 90 to just make sure that we are keeping tabs with our clients and making sure that they are also integrating well into the society. So psychoeducation, CBT, individual and group therapy are also given. Without going to details, these are some of the things that we offer. And then we try as much as possible to reintegrate our clients back to their families, because most of the times we find that they've been living in the streets, estranged from their families, some even lost. And once we're able to trace their relatives, then it's really a good opportunity to allow them to have more meaningful lives. We also have referrals and linkages done appropriately, be it matters legal, education, or jobs. And this has also helped a lot with our clients. Although the big majority that we say we've sort of tried to help out of the streets, we have a challenge to just reintegrate them because we do not have funding to be able to have opportunities for activities that they can be able to make money out of. So if we have donors out there, or people who are able to support in the psychosocial aspect, we'd really appreciate, because the government has really helped in terms of ensuring that the methadone is provided free of charge. So the characteristics of an effective MAT program: if somebody's in the program for 2 to 4 years, at least will be able to achieve something meaningful, although we have people who are weaned off within a year or so. When you have a dose that is above 60 milligrams, then the person is comfortable enough to achieve all the activities that they may want to do. The fact that we have a clinic that is running every day of the week, whether we have public holidays or not, that allows the clients to be able to be taken care of fully. And then we have integrated services, and we have the quality of the therapeutic relationship. Over time, we've been able to, learn our clients and be able to allow them to feel free enough to access the services in the clinic, and that has also helped a lot in terms of their improvement. So then we have cessation. This is really when now we are trying to wean them off the methadone. As I mentioned, at least 2 years, but 1 year we can wean off the clients. Sometimes when a client has been on the program on a stable maintenance dose for over 6 months, then we can consider that, and we can start tapering down the methadone dose. So normally we would not go more than 5 milligrams every 2 weeks, just so that they can be comfortable and adjust. And sometimes we might require us to go higher again to be able to get them, in case they feel that their cravings or there's a tendency towards relapsing. And so it's important that we listen to the clients and we manage them accordingly. But there are some situations that have warranted us to just have somebody stop the program involuntarily. And these have been in cases of indiscipline, or where we have because we have some code of conduct, or maybe rules that we have for the clinic, which the client signs as they sign the consent form for the program. And so sometimes when they go against some of these, it's important that we work it out. And when we are saying we're involuntarily stopping them from the methadone, it's actual taking of the methadone, but we refer them back to the CSO so that they can receive all the other support and care that they would need. But for the cases where we realize that if somebody continues to take alcohol in excess and they're taking methadone and we are risking overdose, then we really have to deal with it. We need to deal with it seriously, so that then we are not risking the person's life. And so we've had to encounter some of those experiences. So I think I've said quite a lot about methadone. On buprenorphine, I will just mention briefly, because we have it available in only one at least as far as I'm aware, in one of the methadone, the MAT clinics in Karuri, that's in Kiambu County. We are yet to start it in Mathare, and I know it's being prescribed in the private sector. So it would just be good to know that we have alternatives apart from methadone that have also been approved in the country. And I from the picture I showed you, I hope we see where buprenorphine was falling under the semi-synthetic opioid. It was discovered in 1966 and has been used for opioid substitution therapy, or what we refer to as MAT, since 1978. In low doses, it will have analgesic properties. In high doses, we give it to be able to take care of the opioid withdrawal. But what is special about it is that it has a ceiling effect, such that beyond a certain dose, it will not add any value. And so that has been very helpful to decrease the risk of overdose or misuse. And there's a picture that will come in next to just show you how it differs from methadone. Maybe in the next slide. So we see methadone is a full agonist. So it will actually block that mu receptor, and in that case, replace the other opioid that we are trying to wean somebody off, like heroin or pethidine or any other drug that we are concerned about. Now, buprenorphine is a partial agonist, so it generates a limited effect. Then naloxone, which I had mentioned as an antagonist, actually blocks the receptor, and so it is very useful in terms of management for overdose. So with buprenorphine, the difference is that it does not produce a high. In the next slide, it's safe and effective in detoxification and maintenance. It's lipophilic, just as methadone. Therefore, it's well distributed in all the tissues, including the brain. It's 96% protein bound, and its onset is within 30 to 60 minutes. It has a peak of 1 to 4 hours, and the half-life is 20 to 73 hours. This is important for us to note, because then it gives it a slight advantage over methadone, which I will share. It's also metabolized in the liver. So we need to be very careful in case there's a severe liver impairment. It has a ceiling effect. And so with that case, then we have no respiratory distress when it comes to issues of maybe taking a dose that is higher than prescribed. It's safe if swallowed by an opioid naive person. Remember, I mentioned earlier that with methadone, even a small dose can be fatal to somebody who has never used opioids before. But we also need to be cautious with other CNS depressants, because we might risk overdose as a result of sedation or respiratory distress, maybe with use of alcohol or benzodiazepine. So some of these substances, we need to really keep drumming it in our clients that they need to find a way of managing it. Otherwise, it will be counterproductive. So we have a comparison of methadone and buprenorphine. And so methadone is a full agonist. Buprenorphine is a partial agonist, as I'd shared. With the methadone, we have a daily dose because of that half-life of 24 to 36 hours. But with buprenorphine, it's possible to actually have alternate day dosing such that a client can take it maybe 2 or 3 times in a week, as opposed to methadone where they have to show up every single day. The advantage of buprenorphine is that it's possible to actually take it home and use it safely without being worried, compared to methadone, where we'd have to be taking care of matters overdose. So with methadone, by the time someone is being inducted, as I mentioned, we do an assessment using the clinical opioid withdrawal scale. Sometimes they might have minimal to mild withdrawal, and it allows us to be able to just start the patient on methadone. But with buprenorphine, the person actually has to be in withdrawal with all the symptoms showing up for us to be able to give the adequate dose. With methadone, there's a high risk of overdose in induction. This is because even as you're trying to navigate the right dose, sometimes the client might feel that they are still in withdrawal, so they want to go and add on to something to make them comfortable. But the problem is that then that creates a risk of overdose. But with buprenorphine, we don't have that risk. As I said, methadone is dangerous if accidentally swallowed, but buprenorphine, it's not the case. Methadone in the long run may prolong the QTC interval, and so then bring a sense of cardiotoxicity, but buprenorphine doesn't have that. Methadone is not contraindicated in liver impairment, but with buprenorphine, you have to be careful. Methadone is relatively cheap. When I say relatively cheap, it's because at this point in time, the country is providing it free of charge. But with buprenorphine, apart from that one center that is offering buprenorphine at the MAT clinic, it's really considered an expensive medication, but you have to weigh the options and see which one would work best. So the formulations that we have for buprenorphine, it's a sublingual tablet. So it's basically put under the tongue. And therefore, if it's swallowed, it will not really have any effect. So it's important that we get the route of administration right. One would require to avoid acidic drinks before administration. And the optimum dose ranges between 16 to 24 milligrams. So our tablets are 2 milligrams or 8 milligrams, and that can be maneuvered accordingly. The other formulation is Suboxone, which is a combination of buprenorphine and naloxone. It is still given as a sublingual medication, but the naloxone has been put in combination to be able to reduce that that risk of injecting it, as opposed to using it sublingually. So what would happen is the naloxone aspect would precipitate withdrawals, which are very uncomfortable. Therefore, if anyone tried to use it in a different way, it would not really work. And it's also contraindicated in pregnancy. So in conclusion, I think I've shared a lot, but I think it's important for us to just know that management of opioid use disorders has a holistic approach, and it requires a multidisciplinary team. From what I shared, we actually have a team of clinicians, we have psychologists, we have we even have HTS counselors, we have pharmacists, lab tech, and nursing team that also takes care of our clients. And addiction is a relapsing disease, so we really need to be patient even as we manage our clients through this recovery journey. Thank you so much for your time.
Thank you so much, Dr. Jacqueline Ochieng, for taking us through that awesome presentation, right from the hand claps, from the emojis. I can see people are just uploading the good work that you have done in just helping us understand MAT. Thank you again for sharing your knowledge. We are really grateful. The presentation has been very informative. We've been able to understand the classification of opioids, withdrawal symptoms, management, treatment pathways. You've been able to outline the MAT program design, really putting out there the multidisciplinary team efforts at Mathare National Teaching and Referral Hospital. We've been able as well to learn about intoxication, overdose, what are some of the signs and symptoms, and also management of the same, and as well methadone maintenance therapy. We've been able to learn what it is, advantages and disadvantages, safety overview, and also other aspects, other maintenance like buprenorphine. So we're really, really grateful. If any one of us does have a question, please drop it in the chat and we'll be able to answer those questions. Maybe Doc, you can take the first question about effects of methadone to a breastfeeding baby.
Oh, effects of methadone to a breastfeeding baby. Methadone is excreted in breast milk, but it's not in a significant how do you call it, to a significant extent. So really, I don't think we'll be worried about a mother being on methadone and breastfeeding. In fact, we really encourage our clients to breastfeed their babies.
There's also another question about, is methadone teratogenic?
Methadone teratogenicity, we have not seen anything recorded in that. If anything, the clients that we have put on methadone, we've not had any issues as far as effect of methadone on the fetus is concerned. Its safety profile is good. And maybe my colleague Valian would share that we actually celebrate methadone babies, because the clients that we've had, the few females that we've had in the program, most of the times when they come after the chaotic or erratic heroin use, they may not even have their menses. And so at this point in time, when they come to the program and they are stabilized, they're able to conceive and get babies, and really celebrate all those babies. The only thing that we need to be concerned about is neonatal abstinence syndrome, and this happens just about the point when a point of delivery, because then what would sound like withdrawal symptoms would happen on the baby. And so we really try to work closely with our clients, and especially the facilities that they choose to deliver, so that we make the team there aware that in case you experience some abnormality in behavior in the child, as much as we look out for issues like, meningitis, amongst other things, we might want to check out for neonatal abstinence syndrome. And there's a way in which it is also managed. So that is also important. Yeah.
Thank you very much. Another question is that how can we differentiate opioid intoxication from organophosphate poisoning?
Opioid intoxication and organophosphate poisoning. Wow, that's somebody who is, I think, first of all, the most important thing is getting history. It would be important to take history, because I know this would be in a case where someone is attempting to end their life in one way or another. Taking history is very important, and also just looking around if there's any evidence of use of some of that. But from what I mentioned with there's intoxication and there's overdose. So if someone presents with a lot of CNS depression symptoms, we'll be thinking about that. But also it's important to just pick out from history, was there history of use of any of these substances? Because if you don't know, then it's also a bit difficult to guess.
Thank you very much for that response. In regards to comorbidities, there's someone who is asking, clients that have been started on methadone, do they also continue with other antipsychotics?
Yes. It's very important. In fact, the advantage we have at Mathare is that we have psychiatrists stationed in the clinic. So in the beginning, it's a bit difficult to identify comorbidities. We're talking about depression, anxiety, PTSD. It might not be easy to identify this within the first 1 or 2 weeks, because a lot of even the withdrawal symptoms mimic some of this, if somebody is withdrawn or they're irritable and that kind of thing. But right from the beginning, we screen for mental illness. There are those who may have come with a prior history and have been on treatment, but there are others who we pick them as we screen them regularly. We do PHQ-9 and for depression. And we also try to look out for anxiety. But this is usually once we've stabilized them on methadone, then now we're able to pick out what is withdrawal symptoms and what is really an underlying mental disorder. And we put them on treatment, an adequate treatment. Part of it is available free of charge in the methadone clinic. Some of it we would ask them to prescribe if it's not within the pharmacy. And it's very important to manage that, because that way then we're also going to achieve good outcomes of the methadone program.
Thank you. Let me combine a question that is asking about cannabis use. So they're asking, how about cigarettes and cannabis addicted smokers? Is there a MAT approach for them? And also someone is asking bang addiction, how can it be treated if a client has smoked bang for more than 10 years?
Wow, okay. I know that's a different question.
Yeah.
We are dealing with opioids, but it's good to notice that even as our clients come in, we do a urine drug screen, which can pick up to about 10 drugs. So you realize that a lot of the clients that we have are polysubstance users. So cannabis ranks very high. Nicotine is one of those as well. Sometimes you'll find that they've used benzodiazepines amongst others. And so the program itself is really addressing opioids, but we also have other ways of managing the other addictions. If it's alcohol use or even just specifically cannabis use, sometimes you might have to use even antipsychotics if they're going to present with some of the symptoms towards that direction. But what I would say is, with the approach that we give, the holistic approach, the psychosocial team also works very hard to try and take them through some of the counseling therapies and psychoeducation to help them just manage that as well. Because if you take care of the opioid use only and we don't address some of the other issues, then we are not really taking care of the person holistically. So some of those services are offered, but not necessarily managed by the use of methadone. Yes.
Okay. Thank you. I think I will direct one question to you and then another one to Kisivuli, a psychosocial question. But for you, Daktari, there's someone who's asking that they have seen some consultant putting patients on codeine syrup before commencing methadone treatment, and they're asking if that is right.
Well, so there are two ways of managing withdrawal symptoms. So what we'd call maybe a short-term detoxification, and methadone, which is really used in the long term as maintenance therapy. So it's possible, because to use codeine, yes, to be able to just manage the discomfort that is presented, as I mentioned, with the withdrawal symptoms. You can imagine someone looking like they have GE, they have a diarrhea and they have a flu and they're very uncomfortable. So it's a possible way to go about it. And I think we've also mentioned use of codeine, not necessarily cough syrups, but codeine tablets in detoxification. But there's a regime for that as well, which if we have access to, I think we'll share the guidelines. We have access. There's also a place for that in the short-term detoxification, but it has to be done appropriately.
Thank you. Maybe Kisivuli, you could take this one. During psychotherapy, could you share tips on how to deal with a patient's irritability? And also there's an issue about relapse. Someone was asking about relapse. So what is the process of getting someone back to the program once they have relapsed? And also, are they allowed to come as outpatients?
Okay, thank you for that. I'll start with relapse. So of course, we've been told by Daktari that this program takes a period of 1 to 2 years, and it's a program that needs the client to come each and every day. So sometimes there are basically other challenges of fatigue, transport, and coming every day you're working. So and other things contribute to a client relapsing. Migration, maybe you're traveling up country. So all this contributes to sometimes to relapse. And Daktari say that we are linked to the community social outreaches who bring the clients to us. So in case of a relapse, we do defaulter tracing. We call them we call their treatment buddies or relatives just to follow up where they are. And through the CSO, we bring them back to the center and follow up with, of course, counseling. And so that is how we deal with the relapse, and we do relapse prevention and relapse management. For irritability, we have learned that through the use of psychoactive drugs, a lot happens to our brain. So of course, through therapy, we are training this person or relearning their behaviors through behavior modification to just let this patient learn the basic things of just anger, self-care, and that. So of course, we do that through counseling, and it's individual based. So we handle a client individually. Yes.
Thank you very much. Just a follow-up question on what you've said. Is there a different management for school-going children now that they need to come to the clinic every single day? That is high schoolers.
So something interesting about our treatment is that we take clients who are primarily around 16 to 18. Kitambo, it was 16, but now we're working with 18. Why? Because of the effect, of course, that this drug has, and also the age. So we primarily do not have school going per se, like they have to go to school, but the ones who we have who are underage, accompanied by their parents for the consent and just knowing what happens in the clinic, they are not going to school. So the few cases of young people that we have are maybe just street kids on the streets and do not need to go to school.
Thank you very much. Daktari, to you, there is a question that any chance that methadone may cause developmental delays or issues in the children born to mothers on MAT through their gestation period?
I don't think we have seen any issues. I might ask. I've seen Esther has just joined. She works closely with our mothers and the methadone babies. Maybe she might mention something regarding that. I don't know, Esther, do you have an input on that? But as far as I'm concerned, we have not experienced any challenges with the children. Esther Valian, maybe anything you've noticed about the children, our methadone babies?
Just apart from the, like, most of them how can I say? We do not like necessarily pick that per se, but there I can't really pinpoint that this is a delayed milestone. But we have, when they're in treatment, the success is more better than when they're out of treatment. So we've seen the babies growing and they're doing well. We can see them doing everything normal. So that is just through observation.
Yeah, and maybe another thing that I would want to mention is that in as part of the comprehensive management and care that we offer our clients, even as the mother is going through antenatal clinic, we have an NC clinic in the hospital where we take the mothers through, and when they are After they've delivered, they're still followed up, and we advise them to take the children, for their respective clinics and get the jabs that they need to get. And so they are really followed up closely. This is mostly done by the nursing team, because they've walked the journey with them right from the antenatal care. So I would say we really try as much as possible to give them the best when they're in the program, but there are times when they fall out. And also you realize that some of the, they may be from a low socioeconomic status. So some of the issue that might come up may not be necessarily because of the methadone, but just because of, the surrounding that they are from. And so we try as much as possible to support. The other thing is we have the CSOs where we work, with whom we work very closely. So a lot of our clients, especially the female clients, we follow them up closely also through the CSOs. But to answer the question, as far as methadone is concerned, we have not seen its direct effects regarding delayed milestones.
Okay, thank you very much. So I'll combine two questions into one, then maybe Dr. you can respond to it. Touching on healthcare workers, that there are many healthcare workers who are facing an opioid addiction and withdrawal. How would they be incorporated into the methadone program while their confidentiality is maintained at the same time? Because we have lost many healthcare workers to opioid abuse and addiction. And just relating to that, how then do we ensure that people who are being managed on medication, opioid medication, that they don't get addicted, for example, during pain, as they're being managed for pain?
Okay, so those are two questions. The first one, maybe the second one, let me address the second one, not getting addicted, maybe for pain. I think really that just has a lot of education that goes with it. If somebody is post-op, prescriptions would be given for that given period of time to manage the actual, pain itself. You realize that if the opioids are used for the right purpose, then they will not necessarily predispose someone to addiction. But now, if beyond now that period where the pain has been managed and somebody has recovered and now it's used for a different purpose, then it creates that euphoric or that high feeling or that feel good, feeling. Then that's where now we're talking about, dependence. So even as prescribers, as people who take care of patients who maybe in pain, in pain management, we also need to be very careful as we give the prescription, and also just explaining the importance of just watching that this medication is used for the right purpose. Number two, for the healthcare providers, yes, we have managed a couple of those. We've had nurses, we've had people working in maybe pharmacies, we've had doctors, surgeons, amongst others. We'll not give, definitely not name the names. But what we have learned is that, again, we deal with each person as an individual. There are some cases where we've actually had to give what we'd call, I wouldn't call it take-home doses, but the methadone is actually delivered to their workplace and they're able to access it from there, as opposed to them having to come to Mathare every single day. So we've tried to tailor some of those with exceptions, and we've seen good outcomes. So it is important that we take care of our own, but really prevention is key. If you really would not want to get yourself in a mess, just don't start. But for those that have been in a setting, we deal with them as individuals. There's some whom we've even had to, just have them in an inpatient setting, sometimes advise change of, workplace or workstation, so they don't have access to some of this medication. But all of it is dealing with the on a case-by-case basis.
Thank you, Dr. Maybe Esther, you could help us to answer. How often is a rapid urine test carried among MAT patients to rule out substance use among the clients?
Thank you, Diana, for the question. So basically, for MAT clients, we routinely do a urine toxicology after 3 months. That is to check if they're adhering well to methadone and if they're having any issues with polydrug use. So after 3 months, we do a toxicology to check how they're faring on.
Thank you. Felista,
maybe just to add on to that, the toxicology, as we say, is really to help us in terms of management. It's not necessarily punitive or for punishment. So sometimes there's those scheduled ones every 3 months that we have to document. But the times when you suspect that somebody has used a substance and you see it's affecting maybe how they're presenting themselves, it's a lot easier when you have a good therapeutic relationship with your client to ask them, have you done this? Have you used this? And many times they will come out clean and tell you, Daktari, to be honest, this is what I did, this is what happened. So sometimes if we're able to ask that, it helps us manage them. It helps us adjust the doses accordingly, but it also saves on resources so that we don't have to keep sending everybody for a urine drug screen. So as I said, it's before it used to be done in a punitive way to just catch those people who are mixing drugs. But nowadays we have tried to be prudent even with the resources that we have. You get that information and you're able to work with it accordingly. But if there's need to have a test, then we do that and we discuss the results with the client.
Thank you for that input. Felista, maybe you could help us answer, are those on methadone therapy and are HIV positive monitored if they're taking their ARVs or on PrEP, since they might also be sharing needles, especially in the case of injecting drug users? I'm not sure if Felista is able to unmute. Maybe Kisivuli could help answer that question.
Please go again.
So the patients that are on methadone therapy and are HIV positive, is there monitoring that you ensure that they're taking their ARVs or are on PrEP, since they might be sharing needles in the case of for the injecting drug users?
Okay. So all our KPs are taking, most of them are taking their medication on dot and on the dispensing window, but all the counselors have, we were told that all counselors have cohorts of clients that they follow up on. So of course the counselors know their KP client. So we follow them on that they make sure they take their medication, which is dot. But few who are stable and very adherent through an MDT, they do take home. But yes, they are keenly followed. We use Kenya EMR to just track them, and just like other patients. So yes, they are keenly followed.
Thank you very much. There's a question if we have any publications so that we can be able to see the success stories from the MAT clinic.
Wow. I don't think we have any publications. That's a challenge to us. We need to be able to document our journey, being the first clinic. So I think we need to think about that as Mathare National Teaching and Referral Hospital. So hopefully we'll have an answer for that soon. Thank you.
Yeah, very soon.
Thank you. As we wind up in terms of questions, there's someone who's asking, for a client who wants a negative urine test for substance screening, how long should they have abstained from those substances?
That's an interesting question. Valian, would you want to attempt that?
So a client who has had a negative urine test.
How long should they, if you want to have a negative test, after how long should you test?
Okay. I think methadone clears. So, Daktari had mentioned that our urine drug test has 12 panels to test 12 different types of drugs. So maybe you're talking about heroin here, or you're talking about methadone, but I'll answer in terms of methadone. Methadone is in the system for like 48 hours. So if you miss your methadone for at least 3 days and consecutive like 7 days, the methadone will be negative. So it depends what you want to test. So for a methadone test, it's around 7 days. But if you do not have heroin in your system and you are coming in for methadone, of course, you'll not be eligible to start the methadone program because you have to be using heroin to be inducted in our system. So if you are not, you prefer you do not come and you do not start.
Yeah, so for the heroin, maybe we can say maybe two to 3 days. You can be able to pick it up, and we not pick it up as heroin. We'll actually be picking it up as morphine in the urine drug screen. So if we don't have any positive test for like morphine in that case, then as we said, yeah, it means that you're not using the substance, which is a good thing. But usually when we are initiating someone, inducting them into the program, then we really want to see that you've actually been using these substances. So that is what we will look out for. 2 to 3 days, fairly enough, you'll not pick it in the urine drug screen. Substances like cannabis can be in the system for even up to 3 months. So if someone got into the program and they've said I've actually abstained from cannabis use, right when we started the program, even if you tested after 3 months, you might find traces of cannabis. So really, some of these things, as we say, there might be evidence in the drug screen, but when you're communicating with the client and trying to get information from them, they'll be able to tell you, to be honest, Daktari, I have not used, and this is how we're operating. So I think it's important to also just use both ways, using the drug screen, but also just having a conversation with the clients.
Thank you, Dr. Nkisivuli. Maybe Daktari, there's a question that they've noted the advantages of buprenorphine over methadone. How does buprenorphine compare to lofloxacin?
Sorry, how does buprenorphine compare to what?
Lofexidine.
Is that one of the drugs that are used in opioid treatment, or which one is that? I don't know who has asked the question, but it would be good to maybe clarify. I don't know the person who asked the question. I don't think, maybe in terms of the medication that have been approved for, how do you call it? Have been approved for management of opioid use disorders. I think even as I was sharing about methadone and buprenorphine, you see, I gave even the history of, how it has been FDA approved for this particular management. So I may not necessarily be familiar with the use of lofexidine in terms of management for opioid use as a maintenance treatment, but maybe it's used off-label to just try and manage some of these withdrawal symptoms. So as far as what you're talking about in terms of medically assisted therapy is concerned, what we know have been approved and even in the country is methadone and buprenorphine.
Thank you very much for those questions. I think we will be able to share the slides together with KNH, the slides of what we have done, and it will be able as well to just be able to help us just refresh some of the things that have been covered today. But I want to truly again thank each and every one of you for joining us this evening. for our webinar, and also to our presenter, Dr. Jacqueline Ochieng. Thank you so much. Thank you, Kisivuli and Esther as well, for sharing your insights on MAT. I think that will be the end of the presentation. Thank you so much again for just staying in and learning together. Have a lovely
Thank you very much, too.
evening.
Thank you too.